Hello guys, this is Dr. KV Singh and today let's learn how to do Phakic IOL surgery, which is commonly known as ICL surgery. ICL surgery is actually a kind of refractive surgery which is very commonly performed for the cases in which LASIK or other cornea based procedure cannot be performed. As you can see, this eye is being prepared, the draping and everything is already done, and because it's a toric case, so I've already marked the cornea. First and foremost, let's see how the loading of the ICL is done. Firstly, the
Before
cartridge that is supplied with the lens is flushed with BSS, and then it is filled with BSS. Along with BSL, small amount of Visco is also added, just to give it better lubrication. Otherwise, full fill of Visco is not required. After the cartridge is loaded, cartridge is loaded with BSS and Visco. We take out the ICL from the bottle. It is supplied in, and we use the sponge tip that is supplied along with the lens to take it out from the bottle. It is a very atraumatic way of taking it out, and we use the concave side to take it out, and the surface tension that exists between the cotton tip in the sponge and the ICL, that makes it stick to the sponge, and we can use it to put it inside the channel that is given in the cartridge of the ICL. Now we use the rotatory motion of the sponge tip to put it or roll it inside. The detailed instruction how it is done, it is given in the package, and that is also available in the various videos that are provided by the company itself. We have to just make sure that the convexity is upwards and all the three ports are facing upwards, and they are in line with the bevel of the cartridge, because this is the way it will be implanted in the AC. And now we just use the cotton tip to push it down so that it does not come out while we are pulling it inside the solid part of the cartridge. Now we use this ICL forceps, and only one trick that we should do here is that we should grab a good chunk of the material of the ICL to pull it inside the cartridge. As you can see, it has tendency, if we leave it now, it goes back. So we should pull it really towards till the end of the cartridge. After that, we push the sponge tip in the injector system and push our cartridge inside the injector system. Now it's time to prepare the eye. First we make the side port incision. We should always remind ourselves that we are doing an Phakic IOL surgery, as we are used to do cataract surgery, and there are many steps which are similar to cataract surgery, so we can become a bit complacent about maintaining the integrity of the anterior capsule, which is very important in this particular case. So first and foremost, what I do in my cases, I make the side port which are 180 degree apart. They are made 180 degree apart just so that the maneuverability of the ICL in the AC becomes simple, and that's after we make the side port incision, we make the AC and we fill in the Visco. When our AC is really deep, after filling it Visco, then we only make the main point incision, because any point of time our keratome, if the AC is shallow, our keratome can injure the anterior capsule, which will really complicate the case further, because then that will lead to the cataract formation and will require explantation of the ICL. So we have to be very careful during our side port incision and main port incision making, that we don't puncture the anterior capsule. After forming the AC, next step would be the implantation of ICL. But in case we are doing a toric ICL, then we mark the placement of the ICL. And I use Menden's marker for that, and it is like any other toric case. Generally what happens that in case of ICL, the placement is around 15 degree either up and down from the 180 degree. Now after that we maintain the position of the eye using the olive tip ICL manipulator, and we implant the ICL under it, and we try to keep it down with the olive tip so that it does not rotate. ICL or any other phakic IOL has a natural tendency to rotate and go concave side up, and if that happens then we have to manually manipulate it and make the concave side down, which can cause damage to the anterior capsule and endothelium. We also should not try to put ICL directly under the iris. We should first put it in front of the iris, make AC with Visco. We should form the AC with Visco, and then after the AC is nicely formed and the gap between cornea and then the front surface of the ICL is maintained, then we should take our olive tip ICL manipulator and try to put the haptic or the plate haptic part of the ICL behind the iris slowly without losing the AC. In case we lose the AC, then refill of the Visco can also be done repeatedly as many as time, but we have to be very sure that we are not damaging endothelium or anterior capsule. While we are inserting the plate haptic behind the ICL, behind the iris, we during that time we also place the toric marks along the marks that we are placed on the cornea. And there are many ICLs or phakic IOLs comes that don't need to be marked like this. They are simply placed in 0-180 degree, and they are known as smart toric, like what comes from Care Group, which is known as IPCL, and it has got inbuilt toricity, and that takes care of the toric part. And what my opinion about when we should use toric ICL is because we are doing refractive surgery, so there should not be any cylindrical power after the surgery. So even if your patient has 0.75 diopter of cylinder, we should use toric ICLs. So now after we have placed the haptic behind the ICL, then we take our hydrocannula and try to evacuate the AC with whatever Visco is there. And now because there is a great tendency of Visco to remain in the AC even after cleaning, so that can cause IOP rise next day, which can happen pretty commonly, and we should take steps to avoid it. But that also warrants that we should do very thorough cleaning of AC after we have implanted our ICL. According to me, one of the most important step, or rather the step that requires learning, and it requires good amount of learning, is how we close our case after we have implanted the ICL, because it's not like cataract in which the AC is deep. In this particular case, AC is basically shallow, so we have to titrate between the IOP of the patient and also the depth of the AC. Generally, we don't like to put air in case of ICL, and we have to close it under BSS only. So that titration is a bit delicate and has a learning curve. So why we don't also go behind the ICL, as it can damage the anterior capsule. So we remain anteriorly and use the jet of our irrigation aspiration cannula through the central hole to clear the Visco that is present behind the ICL. As you can see, this is what I am trying to do in this case. And after that, we with different type of manipulation of the ICL by pressing it down or increasing or aspirating, we can make the AC go shallow and deep, and that wavy motion creates the evacuation of the Visco from all around the AC. As I've already told, it is the closure which is very important in case of ICL. If we close it very tightly, then IOP increases, and if we keep, and ICL, because the AC is already shallow, it is crowded, So ICL cases have a tendency for a shallow AC, and that would also be a problem. So we have to titrate it delicately, that IOP should also be normal and AC should also be maintained. We can gently tap the optic side of the ICL to make it go near to uh, to the anterior capsule and really settle in the behind the iris, and that's how. And we should use the hydrocannula and hydrojet to evacuate the AC. After everything is done, we lose the speculum slightly, so that the real IOP at the time of closing we know. At the end, we put small amount of pilocarpine to constrict the pupil, and basically then we use small amount of blue dye to check whether our side ports are leaky or not. This particular thing is known as blue Seidel test, and that basically makes sure that our AC will not go shallow after the surgery. We put small amount of blue dye at every port side, and we check whether any dilution of this thing is happening or not. And after that, we wash the anterior surface again thoroughly, and then without any patch, we can close the eye. And generally I like to do one eye at one point of time. Many surgeons, they do both eyes together. So after this, you can go for the other eye. And this is what ICL surgery was all about. Thank you for watching. Please subscribe to my channel.